Hello, everyone. Thank you for your attention. This is going to be a 15-minute follow-up deep dive presentation for one aspect of my talk from yesterday's PriMed conference. The topic is going to be the patient-centered medical home model and how a general practitioner could implement part of this in their practice, even if they are not part of a NCQA officially certified medical home practice. For those of you who saw my talk yesterday, this is one of my favorite pictures. I think this is a great snapshot of what chronic care management looks like in the United States these years. We have an older patient who is suffering from frustration, likely a headache, feeling weak and dizzy, and likely related to her medication. So B, she's an 85-year-old colorectal cancer survivor. Again, she's diabetic and hypertensive. She has the additional stress of being the primary caregiver for an 18-year-old who is struggling to graduate from high school. She always has a headache and always feels dizzy. She thinks her meds are causing her dizziness, and she is always worried that her cancer has come back causing her headaches. She is frequently in the emergency department for these complaints, and her multiple chronic conditions are obviously exacerbated by her family and socioeconomic stresses and barriers. I think B is a perfect example of what I'd call the 5% club. So what do I mean by the 5% club? It's related to the management of chronic illness. And again, in the United States in 2014, chronic illness is extremely common. About half of Americans have at least one chronic condition. It's increasing in frequency, and it tends to cluster. Approximately half of people with chronic illness have multiple chronic conditions. 150 million people with chronic conditions, half of whom have multiple chronic conditions. For patients overall, evidence would say that only 70% of healthcare encounters result in high-quality care. And among patients with multiple chronic distractors, those quality metrics tend to be worse. Patients with multiple conditions tend to be taking multiple medications and tend to be at higher risk to have complications and adverse events. And when you add this all together, the 5% of the sickest patients, of what we call the superutilizers, end up accounting for 50% of all of our healthcare costs. For patients with chronic illness, they, as an aggregate, account for 80% of all the healthcare costs in this country. In spite of this dramatic, skewed distribution of both cost and harms, the problem with our healthcare system is we have not changed the system to account for these realities. In 2014, if a 30-year-old with no medical problems calls for a sore throat, what does my office give her? She gets a 20-minute slot to see me, and if I give her antibiotics, I likely bill an E4 encounter. If Miss B shows up with 5 chronic conditions on 15 different medications with multiple quality deficits, what do I get for her? I get a 20-minute slot, and likely I'm going to bill an E4 encounter. This is not the way any rational actor would design a system if they were designing it from scratch. So graphically, what does this skewed distribution look like? It's an exponential curve with 50% of the population accounting for only 3% of all healthcare costs. Again, this is my 30-year-old with the strep throat down there. And up at the other end of the graph here, this is 5% of the population accounting for 50% of the costs. Again, primary care, the system needs to be redesigned to account for this skewed distribution where the physicians are freed up to spend more time being proactive and reaching out to those patients who are at the right end of the curve, and likely sharing the care with mid-level providers to help free up our time for the patients who have more straightforward problems. So what do our patients with chronic illness need? They need proactive planned care for the activated high-risk patient. and they need us to get past the current industry standard of worrying about the patients that are listed on my schedule today and being more of a population manager where we are working as a team trying to maximize the care for the 2,300 patients in our practice. This requires a system redesign if we're going to think in this new population management way. So again, there are many practices in the U.S. As of 2014 who have transitioned and have implemented a patient-centered medical home model. Most places who have done this, it's been with the support of either Medicare demonstration projects or more commonly with insurers. Most of the practices who have implemented this are in states where several of the large insurance companies have incentivized this by paying per member per month fees. In many states, like Illinois being one, there's been very little penetration and very little expansion of the PCMH model. So what's coming in 2015 that might change this to some degree for practices who are not ready to commit and spend the resources and the capital required to get NCQA certification. What's coming next year is a way where practices could dip their toe in the water, if you will, and experiment with delivering some chronic care management. And this could be done on a per member per month basis for Medicare patients. So a finalized CMS rule for last year has laid out the guidelines for what will be billing for non-face-to-face encounters. Again, this is going to start in January 2015, where there will be two new CPT codes where primary care physicians can bill for 20 minutes of chronic care management that is outside of an office visit. These services can be delivered by staff at the clinic and not necessarily the primary care physician themselves. They can be billed incident to the primary care physician. The final CMS rule states that patient eligibility for chronic care management services, patients should have multiple chronic conditions, approximately 3 or more, that are expected to last the life of the patient and put the patient at significant risk for exacerbation, deterioration, or decline. And obviously, we have many patients that are in this condition. I'm not going to go through the exact details on the specifications required to bill for chronic care management services. They are on the screen here. Feel free to pause and take notes. At the bottom is a link to the Federal Register where these are laid out in more detail. If your practice is considering implementing these, again, the resources are here on the slide. The major rules of engagement here are that practices do need to have a CMS certified EHR to bill for this, that practices do need to obtain patient consent at the outset of providing chronic care management services. They do not require consent each month, but they do require initial consent. The patient will be on the hook for a small copay for these services, so that's why consent is required. There is an additional requirement that the patient must receive a copy of any chronic care management service, and I would expect this would be difficult to implement with paper records or using the mail, but would be very easy for practices who are using patient portals. So I would certainly recommend that any practice that's going to implement this, if they have a patient portal system, use that as an easy way to communicate directly with the patient. Again, here are some more details for what's required to bill for these services. At the bottom here, again, is a web link to a great resource. This is a white paper produced for general practitioners who are trying to implement chronic care management services that has frequently asked questions and answers. The proposed reimbursement here is not exactly robust, but it's not zero. This is the proposal for $42 per patient per month as a chronic care management fee, and we'll go through kind of how that math would work out for a practice. The best case scenario here, if you are an average internist and have 2,300 patients, let's say the 10% most complex patients you have, that's about 200 patients. Let's say half of those are Medicare patients. So if you hire some case managers or care coordinators to spend roughly 30 minutes per month coordinating care and making phone calls for these patients, that would be approximately 50 hours per month for one person to manage those 100 patients. Again, if you have an electronic portal such as Epic using MyChart, and you're able to email that care plan to the patient, that would be minimal or no additional time. At a clip of $42 per member per month, a panel of 100 high-risk patients would be roughly $50,000 per year if you were to successfully submit and be reimbursed for those services. Again, this would likely be approximately 50 hours per month of time to do that. So therefore, one case coordinator or one healthcare coach could probably manage 2 to 3 physician panels, and that would give you enough reimbursement to justify hiring that additional personnel so that you can do the outreach that you've wanted to do for these high-risk patients. Again, this is not a perfect solution. I view this as an incremental step forward, but I think certainly having some reimbursement as seed funding for practices who want to, again, dip their toe in the water and start to experiment with chronic care management systems design. I think this is a great year to experiment and see if that option works for your practice. So again, chronic care management, it is coming in one form or another. Either the insurance companies will likely be expanding the PCMH model and encouraging us to do this, or practices will choose to do this on their own as an experiment with chronic care management services. And again, what would this look like as a template? So for practices that want to implement this, these are the structured data fields that would need to be on a chronic care plan. Again, practices can modify this, but I would suggest that this would be a starter checklist that practices could use if they're going to implement this. What would this look like within the EHR? Again, the first step would be that you need to establish a team. Again, with that seed funding, practices would need to hire or repurpose some current clinic staff to be case managers for those high-risk patients. The second step would be to identify your high-risk panel. Again, those patients who've been having readmissions to the hospital, your patients with multiple chronic conditions, your diabetics, your hypertensives, your heart disease patients, your patients with active cancer. Thirdly, you have to establish that role within your clinic for exactly what are the expectations for your case managers or care coordinators, and make sure that everyone within the clinic is on the same page with the relegation of tasks. Probably the most time-intensive portion would be for the primary care doc to sit down and draft those initial chronic care plans. What I've done over the past couple of years is to add that to my most recent visit to make that part of my dot phrase. When I'm seeing a patient who needs care coordination, I have this checklist built into my dot phrase for that clinic encounter so that I can build in that plan during a clinic visit. Once you draft those chronic care plans, then you need to specify a consistent data field where every member of your team can easily access that chronic care plan. You next need to have a secure team population management list where all members of the team can have access to the list of patients being managed, and I'll show you how to do this within Epic. Once you've set up your list and you have your care plans, then you need your team to get to work and make outreach calls, encourage those patients to come in for planned visits, where those chronic care plans can be modified and implemented. Periodically, practice to practice might do this differently. Maybe this is a weekly huddle, maybe this is a monthly huddle, where you need to sit down with your team and run the list, if you will, and modify those care plans as appropriate. Once you've agreed on that new monthly care plan, you need to email that to the patient themselves so that they are activated and informed and in the loop on your plan. And finally, CC that plan to any of the continuity specialists who need to know the coordination of care needed for that month. The final step, and I think this is where the medical home model will ultimately make a difference. The final step of anything in the medical home model is the quality improvement aspect, where whatever system you put in place this year, you need to set aside time, maybe every 6 months or every 12 months, and ask yourself, is this working? Assess your progress and adjust the model. So again, I view this as an incremental step, but I would imagine a lot of practices, if they implement this each year, planning, doing, studying, acting, and making it better over time, this is a service that, again, could fill a need for patients who need more intense proactive outreach, and again gives a way for seed funding for the clinics that want to be doing this. So if a practice was going to do this, what would this look like within the EHR? So here I'm within Epic. This is a common electronic health record used by many practices. Obviously this would be slightly different for practices using a different format, but I'm going to at least go through here and show some examples. So within Epic, there is a patient list feature, and here I've created a patient list called Team Huddle List. I've deleted names so you can select what columns you want in here. You would go within the patient list. You could create a new list. You can select what columns you want to include in your list. Under Advanced, you can specify who to share your list with. So obviously you would share this list with your triage nurse, you would share this list with your case managers. In my case, I'm working with medical students. I share my list with my medical students. So on here, I've created a list with, I've kept names out for confidentiality. I've got age, I've got sex. I've included department specialty comments, and this is where I put the chronic care plans in that field so that it appears on our team list. We have medical history. You can include last blood pressure, last BMI, so that you can scan the list and look for some patients who might be out of compliance. You can quickly look at health maintenance issues. Again, seeing colonoscopy compliance, some other, if you used best practice alerts, kind of see what's out of compliance there. Within a patient chart, again, within the snapshot feature here, you can quickly go down. Again, you need to pick a consistent field where everyone on your team knows where to find that plan. What we've been using is the specialty comment field, and that can populate directly into your team list. I would encourage you to create a dot phrase. So for us, again, my students work with me. We call them the Education-Centered Medical Home. We have a dot phrase for a chronic care plan. And here's the checklist that I showed you in our earlier slides. Care coordinator, I would say Katie, for example. Next office visit goal, let's say this patient needs to be seen next month. Last patient contact, let's say I called this patient today. Chronic care management plan updated today. Conditions being managed, let's say this patient has diabetes, hypertension, colon cancer history, anxiety. Her team, let's say she has a cardiologist and a neurologist. I would put their names and contact information here. When's the last time we went over her medication list? Certainly as part of any monthly care coordination phone call, that would likely be part of that conversation. So let's say my care coordinator did that today. active problems for the month. Let's say she's having vertigo, and we're trying meclizine. Let's say her diabetes is uncontrolled and her glucose is over 400, and we're starting insulin. Let's say blood pressure controlled, and let's say stress, grandson causing increased stress. All right, interventions, let's say we referred for counseling, we started insulin, started meclizine, continued hypertension meds, treatment goals. This would be more the patient-directed aspect of the care. The patient wants to reduce her stress. She wants to stay out of the ED for her glucose, wants to be on fewer meds. And let's say she's due for an eye exam for her diabetes. Let's say she is due for a foot exam and she needs a flu shot. Expected prognosis, if she does these things, would be good. And once we update that, again, that's going to go directly into our patient list. So if we go back to our patient list here, now this patient, this is visible right to the rest of our team. They can easily click on this and get details. Again, that would be easy enough within this patient if we were going to bill for this non-face-to-face encounter. We can select a ZZ test ALPA, our fake patient. We can do a new encounter, let's call it a clinical update. And we could very quickly now, we know where that care plan is. It's in the snapshot under the specialty comments. We would very quickly go in here, and again, we could easily go to the snapshot and copy that care plan and paste it into our note. We can go to level of service, where we could CC this note to her other providers. We would select the level of service. Right now, this is not live. We can't bill for this till next year, but we would go in and select the G code for the non-face-to-face encounter. And our last step, again, if our patient has an electronic portal, if they have an active MyChart account, we could email this directly to the patient and call this her monthly care plan. Obviously, we might there might be some things here we might need to proofread and make sure that we've removed some medical jargon and made it more patient-friendly. But again, I think this is something, if case managers or care coordinators are doing this consistently month to month, I think this is something they could very easily become efficient with, updating those plans and, again, getting them to the primary care provider as well as to the patients. So, chronic care management, it's coming. Again, whether or not it's going to be dictated by the insurance companies that charge a per member per month fee and ask the practices to become a certified medical home, or whether or not it's going to be one practice at a time, dipping a toe in the water and doing this on their own with some small carrots from CMS to do care management services. Again, I think this is coming. Our patients need this. Clearly, the current system is not working. We need to pay more attention to our patients with chronic illness. The evidence is overwhelming that that's where the adverse events lie. That's where the cost savings could potentially be found. That's where, as internists, we need to be spending our time. Again, these would be the steps to implementing a plan like this. Again, refer to some of the slides for detailed links to some white papers and some publications from CMS if you want more details on this program. Thank you again for your attention. I hope this talk was helpful. Good luck for those practices that are going to try to implement chronic care management services for 2015. All right, thank you very much.